So I want to start by asking the panel, what are some of the biggest challenges to Black communities engaging in clinical trials today? Anyone feel free to respond.
I can start. I think one of the major challenges is the challenge of perception and the fact that for years, decades, even in the United States, Black people have been disproportionately harmed by public health, by medicine, and by research trials. And even though they're, by virtue of that harm, the scientific community has made progress in ensuring safety, there is a disconnect between the perception of the safety and the actual safety itself. And I think that that is the major challenge that we face when dealing with such a crisis that is disproportionately impacting our community, given a range of issues that Black communities are dealing with during this time.
Yeah, I definitely agree with Marlon. I think one of the other challenges is that there's an inherent failure to engage Black communities in research from the beginning, in clinical trials from the beginning. There's certainly been a great sort of addition of community advisory boards that's been added as an important component of many of these trials. But even that sort of the relatively late addition of that particular component of trials, given the history of atrocities and inequities that Dr. Bailey already described, it's been kind of late in coming. And so I think that doesn't really help alleviate any of those atrocities. I think the other thing is that, community advisory boards are great, but they're advisory. They're not developmental or formative in many cases. And so clinical trials have already been developed and designed, and then they're brought to community advisory boards to advise them on moving forward with decisions that were already made prior to getting any input on the priorities or concerns of the communities themselves in which you might want to do that trial in. So I think that's that overall failure to engage communities, Black communities in particular, from the beginning of the development of a trial or even the development or conceptualization of a research question is one of the challenges for engaging Black communities into research, into clinical trials in particular.
And I'll just jump in by saying I think it boils down to also trust. I think back historically when we talk about trust in research, trust in the medical establishment. Oftentimes, folks will say, "Well, you just point back to Tuskegee, and that's the only thing." But if we take a step back and look historically, going from slavery with the first president of the American Medical Association, who mastered his craft on slave women, you have to go back to trust. And I think for us for communities to trust researchers and trust the medical establishment, it will require some perhaps confronting the past and apologizing for that and moving forward.
I think my, panelists have really touched on a lot of key issues that are at bear here. I was part of another program yesterday where we were talking, and one of the community advisors said, this work cannot be about us if it doesn't include us, right? And so kind of touching on what Errol said, Black communities and communities of color, period, need to be involved in this process from the very beginning, because then they can help set the priorities and drive the agenda and, make sure that whatever the return is of that research project is really valuable to those communities. But we haven't seen that historically, nor are we seeing that moving forward. So when you layer that on top of historical context, as Marlon said, and really just what we're dealing with today, right? So, we're having this conversation about COVID and Black communities, but many of us are still mourning the fact that Breonna Taylor was killed in her own home and doesn't have justice. So you layer all of the things that are happening today on top of now this pandemic, and then asking Black people to engage in research like this, it's very, demanding and taxing And we cannot talk about these things in isolation because they are all interrelated.
Can I just add one more point? I think well, two more points if I can. One, I think, there's a sort of overall general sense of distrust because of the things that have occurred and that have continued to occur. But there's also specifically a legacy of distrust with academic institutions by their surrounding communities. And so the clinical trials themselves and research themselves happen at those local sites. And if there's distrust with the institution that is in your community that you go to for healthcare, then that's going to make it very difficult to engage in research in that space if that distrust has not been repaired by those local institutions. I think the other thing I would say is, as a person who's a researcher in academia, there's also a lack of diversity and representation among principal investigators of Black and Brown researchers. So there's disparities in funding and disparities in academic advancement. And so our voices that may be more in tune with the voices of our communities are oftentimes absent in those upper levels of academia and within the fundings of these larger clinical trials.
And if I could,
Oh, go ahead.
If I could just piggyback off of that, I know Stefan did a really great job of introducing us in the CoVPN. And I think part of why we, as representatives of the Black African American expert panel advising the CoVPN, are here today. I think this is a really important introduction of this panel to the community to know that within the NIH funded studies, the phase 3 studies that are going on, and keeping in mind that not all of the studies are funded by the NIH. And so, just keeping that in mind, but of the NIH funded studies that these panels have been put together, so groups specifically to address issues that might be pertinent to the Black community and making sure that the proposals are being rolled out with an eye towards that community. And there's one specifically for Hispanic, Latinx, for Native American, Alaska Native populations, and also for older adults. So I think it's important for the public to understand that, as Errol mentioned, this lack of representation, which is a whole nother subject that we could even, get into further, at least for this phase 3 trials that are sponsored by the NIH, that this group, the CoVPN, has made an effort to bring Black voices to the table to inform what is happening right now.
And I just wanted to add to what Dr. Osaka said, that it's important for us to let you know that we exist. And speaking of distrust, one of the more optimistic things that I can say is that I trust my colleagues. I've been in this academic research, social scientist world for 20 years, particularly around public health, for 20 of the 30 years of my career. And I have seen a lot of, lack of diversity, and I've seen that increase because people like us have been pushing for it from within the academy, training students, training people to go into this field and to have an investment, to make an investment in this area in terms of their careers. And so I have very few optimistic things to say about this particular issue, but this is one of them, that I trust my colleagues, and we have put together a brilliant panel of experts who are from a variety of fields, a variety of forms of training that address health disparities, medical issues, biomedical, vaccine trials, a whole range of things. And I think that this is a step in the right direction, that we can provide a source of good information in the midst of another pandemic of disinformation that we are experiencing. We can provide good, accurate, honest information about this vaccine trial process.
Thank you for that. I think the points around trust and mistrust and the relationship that you all have with the CoVPN is serving as external panelists on the Black and African American expert panel, providing expertise and perspective and sort of ethical considerations regarding the protocols and reviewing study materials, I think is a really important point to reference. So thank you for bringing that up. I would also like to ask, sort of in relationship to this notion of trust, and thinking back to some of the historical examples that you all provided about where it did not go well. And for many folks, you know, it was not just loss of health, but loss of life. Can one of you talk about, or one or more of you talk about, why enrolling diverse people in clinical trials might be important?
So I can kick this off. And, you know, I think it's important that when we talk about past experiences that have not gone well and learning from that, that it's also important that we reflect upon research relationships and research findings that have gone well. And those tend to be, again, you know, experiences based in research that are conducted by investigators who tend to connect with that community. So when we talk about representation in biomedical research by Black, Hispanic, Native American populations, individuals from those populations conducting those research studies oftentimes have a level of cultural competency that leads to success in those trials. When we look at other research and community engaged work that tends to be successful, engaging the community from the very beginning in a culturally competent way, ensuring that those who participate in the research from the community perspective, that they are compensated for their time, and that whenever there are research findings, that it's reported back to that community in a way that makes sense to them, for them to use those findings in their community. So those are examples of things, you know, that have gone well in the past with other research studies and could go well with these current vaccine trials if those decisions are made. Now, why is that important? We know that COVID-19 is disproportionately affecting Black people, Hispanic, and Native American, Alaska Native individuals. They're being infected at higher rates. So to date, we now have over 200,000 people who have died from this disease. We know of those who have, you know, died from it, that even though Black people only make up 13% of the population, they make up 21% of the deaths. And we also know that those who are dying are now, you know, less so in the cities, but more from rural areas where it may be even harder for them to get access to testing and access to treatment. So why is it important for these communities to be involved in these research studies? Because their overall, you know, these are the highest risk populations, and not because of their race or ethnicity. These are the highest risk populations because they're the ones who are getting exposed the most, because they're in jobs where, you know, they have to continue working. And it may be in the medical field, but it may be in grocery stores, it may be delivering. For whatever reason, individuals in those roles have to contact the community, so they're more likely to get infected. We know that even healthcare workers who are Black and Hispanic in healthcare settings have less access to personal protective equipment. So, you know, there are a multitude of factors why, you know, those individuals from those groups are at highest risk. But if we don't have a vaccine trial that includes the people who are at highest risk, once the vaccine is available, we won't know if it will work in those who are at the highest risk. So that's why it's really important for individuals from the very specific groups that I mentioned that are represented in the expert panels for the CoVPN to be part of these trials.
I just want to add to that and answering that question to talk a little bit about another difference between what has been seen in the past and what we're talking about today. So if you think about overrepresentation in research and underrepresentation in research, if you see that individuals, or for the Tuskegee trial and some of the other trials that others have talked about before, there was an overrepresentation of Black people or people of color in those trials, but they did not get the benefit of any of the research findings. They just got the burden of the research, right? So they got continued with living with the disease that there was a treatment for, to find out more information that was going to benefit other populations. If you have an underrepresentation in current research with the COVID vaccine trial in particular, then those who are underrepresented in those trials are not going to have a fair distribution of the benefits of that research. So really saying exactly what Rachel was saying, if we're not present in those trials, we can't be sure that it's going to be effective in those populations that have greatest risk. and we're not going to get equal benefit from the findings that may come out of those vaccine trials.
And I'll just add that we're dealing with convergence of two pandemics. You have the pandemic of racism and the pandemic of COVID-19. And for some communities, it's a convergence of three pandemics, if you include HIV into that mix. And so as I think about that, I think about health disparities. I think about disparities that have surfaced shortly after PrEP was made available for the prevention of HIV in uninfected individuals. And I think about that in terms of if a vaccine becomes available, we're not part of the trial. We don't we don't trust the vaccine. It creates another disparity as well. And we already know what those disparities can lead to, so we won't need future studies to find that out. Just include us on the front end. I think that it'll include more people participating in vaccine trials that are really affected or disproportionately affected, so people that look like myself and my other panelists.
I don't have much to add. It's just I'd like for us to make the audience out there to keep in mind the social context in which this is happening, where we're dealing with massive unemployment, massive wealth, socioeconomic disparities that Black and brown people, Black people in particular, are disproportionately impacted. We also are dealing with people who are underinsured or have no health insurance whatsoever, which even what little health insurance we have is also a threat. And when we take into account what folks like Dr. Fauci and others have been saying, is that there are long-term effects and long-term health conditions that are a consequence of having COVID-19. And those long-term, and we're still learning more about this virus, but those long-term impacts really disproportionately impact folks who don't have access to healthcare, who are socioeconomically deprived and living under difficult conditions in that respect. And so we are really dealing with a multi-pronged catastrophe that science can help if our administration, the way in which this issue is being dealt with would actually listen to the scientific community, would actually trust the scientific community. And so part of the challenge here is for us to make sure that you have information from folks in the scientific community, so you can see through the fog of disinformation and confusion. So this becomes really important in this discussion.
I absolutely want to echo that. Thank you so much for bringing that up, Marlon. We know that there are people who are listening today who, for personal or philosophical reasons, will not participate in the vaccine trial. And that's okay. And we also know that there are people who are listening today who have already decided that they will participate in the vaccine trial. And that's okay too. What our goal here today is to really, help dispel some of the misinformation that has been released about a lot of, the process that's, in the news right now. And what we also want to share, again, coming back to the fact that, we're only 4 of the individuals. There are about, I want to say maybe 12 to 15 of us total on the panel. And so you'll likely get to meet other people on the panel throughout the season. But to understand that we, as these 12 to 15 people, are trying to bring voice to these issues. And we're trying to make sure that the science that is being released is sound. And if, hopefully if our recommendations are received, that you as a Black community know that you've had a voice in this, and therefore that you have the information that you need to decide whether or not you will participate or not. And we will get to a discussion around whether you take the vaccine when it's becomes available. So I'll wait on that. But really the goal of this conversation is to talk through the information that's existing, the process, and provide you with some resources so you can make a decision that's in the best interest for yourself and for those that you care about in your communities.
Thank you for that. So Marley mentioned a moment ago about employment and housing and income inequalities. And for people who may not follow the literature, can you say a little bit more about what that means in relationship to the decisional process about engaging in clinical research?
Well, I mean, I can say one thing, I'll let my colleagues add to it, but if you're worried about where you're going to live, if you're worried about not having enough food on the table, because we have to remember that right now, massive unemployment, there is massive homelessness and housing instability. When you have homelessness and housing instability, you have food instability. So all of that, when we look at holistic health and we look at decision making, people, the context out of which people are making decisions about whether they participate in something or not, that has to be on the table, because it's like folks don't have a place to stay. folks getting kicked out of their home. And so that becomes the first priority over even participating in a vaccine trial for a, I mean, dangerously infectious virus. And that in the public arena, in the media arena, we're talking about these things separately. We're talking about them as though people are dealing with them separately. So you like, okay, I don't want to get COVID, and then that's separate from housing, and I don't have enough money to pay my rent, and I can be evicted, which is separate from how am I going to feed me and my family. Those things are happening to people simultaneously. And so that becomes really, really, really crucial in terms of how we talk about it. I mean, we need to talk, whenever we mention or talk about what's happening to our communities with regards to COVID, we have to always talk about it within the context of healthcare, lack of access to healthcare, housing, homelessness and housing instability, food instability, unemployment, or underemployment and unemployment.
Yeah, those are excellent points, Marlon. It reminds me of sort of the work that I do as a clinician and taking care of young people who are living with HIV. And as a clinician, oftentimes my first and important focus for me is going to be making sure they come to their visits, making sure they're taking their medicine, making sure that they are getting their labs checked, making sure that they're staying healthy. And those are also the goals that my patients have as well, but they have a lot of other things that they're having to deal with on a daily basis. Forget about COVID even before then, plenty of other things that oftentimes people who are living in poverty or working class conditions, or really in any setting within this country, as Black people in this country, there's many other stressors that people have to deal with. And if my only approach is going to be to call them and nag them about coming into their visit, but I'm not assisting them with any of those other stressors in their lives, I'm not taking that into account when we're making appointments and we're creating access to the clinical space and access to laboratories and access to medications. If you're not considering any of those things, then you're not going to reach the goal that you both have together. And so similarly with some of these trials, I think the extent to which they are accessible to people who have many other things that they are dealing with, struggling with, working on, that access is limited by the complexities of a trial, or the extent to which they have to jump through certain hoops to be eligible or to participate. If those things are not addressed, then people are not going to participate because it's not, they're not able to. And so I think that's a lot of the recommendations that we've been giving to some of the protocols that we've been reviewing, is around making sure that everyone has access, and ensuring that the protocols, the recruitment, the treatment plans that are part of the trials are really accommodating some of the struggles that people might have.
So, to elaborate on that, one of the things that we as a panel, we've already done is we've reviewed 3 of the NIH funded COVID-19 vaccine trials. And after reviewing those three, there were certain themes that were standing out. And to Errol's point, one of the themes that stood out to us as a panel was the fact that a lot of these vaccine trials were expecting individuals to jump through hoops. So as a panel, we wrote a letter to Drs. Fauci and Dr. Collins, and we pointed out several, sort of issues that we saw as being problematic for the Black community, for Hispanic and Native American, Alaska Natives, as well as those who are older individuals. And one specific thing that I wanted to mention is this reduction of barriers to participating in the vaccine trials. So not only recognizing the fact that life is happening and all of the hardships that we just discussed are going on, but that if if these trials want to enroll higher numbers of Black and Brown people, that you may need to provide transportation for them, and that you may need to provide childcare for them. And so building in those services as part of the vaccine trial to encourage enrollment. So just to kind of give you a flavor of the sort of conversations that we are trying to inspire and how we're using the power that, we have, sort of been extended as part of this process to help bring change to the communities that we care most about.
Thank you for that. One more question that I would definitely like to ask. I'm really curious to your responses. Given everything that you've said about trusting the science and allowing science to sort of lead, if a safe and effective COVID-19 vaccine were to be approved, would you take it? And would you recommend it to your family?
I could take that. I would say yes, depending on what approval means. If approval is based on science and evidence and not political or economic expediency, then yes. If it's not based on science, then no, absolutely not.
And then the next question is, how do you know it's based on science and not political expediency? Yeah. And I think that's a very legitimate question. I think the theme here is trust in the science, not trust in folks who have their own agenda. And, to answer that question, it will take some reflection on my own part in terms of, is it safe? Is it effective? Did it went through the levels of the review process, and folks, the governing body weren't like overruled on it? Then sure. I just saw in the news today that the governor of New York had announced that we will review as a state the findings before we recommend it to our citizens. And so I want to just throw out there too that you have layers of protection within the system to ensure that it's not because of political expediency why a vaccine is issued. And so I did that dance just to say, if it is not based on political expediency or someone's own personal agenda, definitely I will take it and recommend it to my family.
I will say what they said, pointing the finger, what they said. But I think to be honest, and this is a time that I can't say that I have seen before. You used to I am one who has had criticisms of the CDC, but I think we might disagree on some of the conclusions, some of the design of the science, but we could really rely on the CDC, especially the leader of the CDC, to communicate things in a clear, reliable, scientifically sound way. That's just not the case. Let's be honest. That's not the case right now. So I think that that's a complicated question. And, I agree with what my colleague said, but, it's really difficult. And I think we need to kind of see, and maybe we should make sure that we communicate those layers, because the everyday person doesn't know. And I'm not, making any assumptions about people's level of education or anything like that. But the everyday person who's not a scientist doesn't know the different layers in this process. They listen to what they see on the media and they either believe it or not, right? They hear it or even believe it or not. And we need to expose people and make this scientific process more transparent. Because right now it's not as transparent as it should be. That could then yield more trust from communities like ours that have been disproportionately lied to and harmed by so-called science. And to see the transparency, and transparency would reveal that there are stopgaps, there are safety measures, that there are scientists who are career scientists who believe in science, who listen to science, who do good science, who design good projects, right? And that there are advisory communities that help in that process that you can rely on, right? In this political moment, it seems like everything has been politicized, but there is a space, I think, and Dr. Harris pointed out what the governor of New York, the Governor Cuomo said, look, we gonna review this on our own. Let's be clear, because we need to protect our folks, because we don't know what else is going on elsewhere. But I think that becomes a part of the question. I know that was a kind of a long answer, because that's where my mind is, because it's circulating in my head. I'm not sure. So.
If I could jump in, because we're talking about how the scientific process is not always transparent. And for those who are not immediately in touch, they may not know what the tells are. So I would say there are a few tells. One is the timing. When does the vaccine become publicly available? If a vaccine is available next month, no, we are not taking it, because the clinical research timeline does not allow for a vaccine to become available in a month. If the vaccine is available in a year to a year and a half, yes, because that means that the right safety checks were, what the right safety checks occurred to make sure that the vaccine was safe for public release. You need to ask, where is the information coming from? Are you hearing about this from communities you trust? Because if the answer is yes, then it means that somebody has gone through the trouble of breaking down that scientific information to those communities to make sure that when you, as the consumer, receive it, that you understand everything that there is to know about the vaccine. If you're getting information from somebody you don't trust, or the people that you do trust know nothing about it, the answer is no. Are you hearing in the news stories like governors saying that they're reviewing, the process? Are you hearing stories in the news like the FDA saying they're, enacting more strict regulations? So all of those are tells. And if you're not getting that information, then, I personally wouldn't, if I wasn't getting that information, I wouldn't take the vaccine, and I wouldn't recommend my family and friends to do the same. But if the timing is appropriate, if I'm hearing it from communities I trust, and if I hear in the news that there are extra layers of, checking the information that's coming out as well as the safety of the vaccine, then yes, absolutely, I'll take it.
I heard something on CNN today as I was driving, and I don't remember who it was because I couldn't see them because I was driving. But the individual said that a vaccine does not only have to be safe and effective in order for it to work, it also has to be trustworthy. And I think that's what we're all talking about. People have to trust that it's safe and that it's effective for them before they're going to take it. If we have a vaccine that's out there that no one's going to take, then it's not a safe or effective. If it's not trustworthy, then it's not going to work. And I think that's really the crux of what we're getting at when we have to make the decision about whether or not we would take it or recommend it to our families. I saw that somebody in the chat said something about that some locations may be at a disadvantage if there are states that are willing to put additional checks on the trustworthiness of this vaccine. There may be other states that are not going to put that trust. And that may be true. That's another reason why November 3rd is really important. I'll just leave it at that.
Thank you. What they say, and I just have one other thing to add, but they laid it out. They laid it out. The other thing I need to add is that a vaccine also can be effective within the context of other safety measures around this epidemic. The problem that we face is that we don't have a national strategy for testing. The national strategy doesn't include contact tracing, quarantining. There's a patchwork, different states, different jurisdictions doing different things. which is why you see these the rates going up and down, up and down, up and down. We need a national strategy. We also need a national strategy or a national mandate for masking. And so we have all of this debate about masking. That's kind of a mess. If you're thinking about a vaccine, the vaccine is not a silver bullet. The vaccine can only be as effective as other safety measures designed to reduce the level of virus in the community. It works with that. So that's also a problem that we're dealing with, because right now the vaccine is being talked about, not among us, but in the larger community, the larger media sphere, it's being talked about. It's kind of a silver bullet. No, boo, we got to do this other stuff. We got to do this other stuff.
Which includes getting the flu vaccine.
Right, which includes getting the flu vaccine, right? You've got to do this other stuff. So for folks out there, one thing that you can do is take care of yourselves and your community and other people by practicing wear the mask, doing the masking, testing if you can get one, if you can get one, because that's still a challenge. Practicing social distance, you've got to do all of this other stuff in order for the vaccine to actually be as effective as it could be. Yeah, I just wanted to point that out.
Thank you for that. So I guess the other question, since we've talked a bit about the health inequities and you all have sort of laid out very clearly, what sort of the implications are for regarding this in trust. There's been polls that have been put out by some of the media that suggest that the majority of the Black community here in the United States will not take a vaccine immediately if approved, and that there's a suggestion that folks will wait some time period before taking the vaccine. And I'm just sort of curious to hear from you all. One, sort of what is your reaction to that? And two, what are your thoughts about the potential impact on health inequities that are COVID related as a result of that?
I'll start first. I'll say that earlier in the pandemic, I believe there was a lot of mixed information or misinformation around COVID. How you protect yourself, who was at risk. And keep in mind, going back to the point Dr. Bailey said earlier, even the CDC lists race and ethnicity as a risk factor for COVID back in April, May, until that was removed. Again, that was listed not factor in the socioeconomic factors and the social determinants of health. But I will say that we have to take a step back. Even if a vaccine becomes available, and it's, I think at some projections, that earlier projections said that the vaccine would be around maybe second or third quarter of next year. So, even looking at that timing as well, and where we are, it seems like a long ways ahead. And so we will need to, going back to Dr. Bailey's point, to do some of those safety measures and continue those until a vaccine is available. The other thing that I'll point out too is, we brought up trust, and I said a lot of that misinformation, again, especially that was geared towards communities of color. We as clinicians and as researchers, we're gonna have to clean up some of that. And it's sad that that's gonna be our job, because I think we're gonna have patients who are coming in that we're gonna have to convince to take the COVID vaccine. And what do we tell those patients when they say, listen, I've heard this, and they're experimenting on this, and the third. So we're gonna have to do a lot of that cleaning up. And I think, I won't say that we're powerless as clinicians, but it's gonna be a struggle. Because I think some of that misconception, and with the survey that you just pointed out, Dr. Wallace, some of that is already baked in. The distrust, the skepticism, and you're going to have the hesitancy all because of that.
Yeah, I agree that a lot of it is baked in. I would say, though, that going back to that point around trustworthiness being an important part of the vaccine development process, if Black communities and members of Black communities and other communities that are at higher risk decide to wait, then we failed to ensure it's trustworthy. We failed in the vaccine development process. It's just, that's what it is. It's a failure. And I think we have to own that. I would say that it's also understandable given the failure to correct past wrongs and really effectively communicate the process that has been put in place to assure that those wrongs don't occur again. I think people are not aware of all the things that have been put into place in research in particular to ensure that people are protected as a result of the poor and heinous things that have been done in the name of research previously. People don't understand it because we haven't communicated to them. But I also really love Orlando's point around the responsibility of healthcare providers to then do the work once a vaccine is out to ensure that their patients understand the vaccine, understand the safety around the vaccine, and are comfortable receiving the vaccine. I think a lot of times us as providers, we fear running to somebody who does not want to get a vaccine because we haven't quite figured out how to explain it to them, what the purpose of it is, why it's important, why you might feel side effects, and that's actually not the disease itself. We're just going to have to be able to do that. I think that this is a time when we've seen 200,000 deaths. We've seen disproportionate burden in many of the communities that we take care of and the communities that we live in and that we're a part of. And so as those of us who are in healthcare, it's going to be our responsibility to figure out how to let people know about the safety and effectiveness and the trustworthiness of this vaccine when it becomes available.
If I could, even expand on that, the issues around trust have been building for 400 years. Black people have been in this country, and we can point to, example after example after example where Black people were excluded or exploited or misused, abused within medicine and healthcare systems. So to think that, we are going to repair, and even we as a panel, the 4 or 5 of us, Black people, that we are gonna, repair this trust and help increase enrollment in a vaccine trial, that's not going to happen. Like, I can just say that right now. And I also believe that, yes, there is some responsibility for healthcare providers, but I think there's a greater societal responsibility to fix these errors, to begin the process of building trust. And part of that begins with the drug manufacturers who are running these trials, hence why our very specific recommendations to them about how to address some of the issues that we have seen in the trials that specifically are pertinent to Black and Brown communities. Part of that will be the healthcare systems themselves and the communities in which they exist in. And that work already needs to happen, right? So that work needs to happen now. Now, we understand there are some barriers to that work happening due to certain executive orders, but it does not negate the fact that that work needs to happen. And until that work happens and happens consistently, that, we, as whether it's as clinicians or as researchers or as, people who are deeply involved with our communities, we're not going to be able to convince anybody who doesn't want the vaccine to get it. But if there are specific efforts made now to begin to build, answer some of those past wrongs, and an attempt to, begin to form a relationship that leads to eventual trust, and we have about 1.5 years likely before this vaccine is out, then hopefully the things that we do now will be able to pay off, when it's time for individuals to receive the vaccine, so that we too can benefit from the effects of the vaccine.
I'll only add to that because I think my colleagues have eloquently captured the answer to the question. The only thing I would add to it is that, this whole notion of perception is also about how we frame the issue. And what we have to, as researchers, for us, we're good and we are doing this. And many of us, our work is the appropriate framing. But when we communicate to the larger community, the framing has to be that this is a part of the larger context of social, racial inequality. What this pandemic has exposed in the US is how deeply racially inequitable our society is, and how deeply, deeply messed up our healthcare system is, that our socioeconomic ecology does not work for the vast amount of people, and particularly disproportionately impacts Black and Brown and Native and Indigenous populations. We have to always, we cannot allow for the media or the public representation of this pandemic, of this virus, to be framed as a singular thing. It has to be within this larger context. And even if it is mentioned, we have to link it together because it is inextricably linked, inextricably linked. And that, I think, going along with everything that my colleagues have said, is that that is one of the ways that we can begin to build trust, because what communities are saying, look, you don't really care about me because you don't know my entire situation. And you talking about, you talking about COVID. What about I ain't got no food? Right? I'm standing in this food line. I mean, so, that's because this is this is what I've learned from my work on HIV. And you all on here know who do HIV prevention. You can't talk about HIV without talking about these other socioeconomic, housing instability, mental health, substance use disorder, all of this stuff that disproportionately impact the people that are disproportionately vulnerable to HIV.
Yep. None of us on this panel were surprised when we saw the race data on the disparities in this disease. None of us were surprised because it falls along the same patterns of everything else that tends to disproportionately burden those folks who are poorer, who have live in crowded spaces, who have less access to education, less access to money, less access to healthcare. We were not surprised at all by this. And that really speaks to what everyone's been saying. There are fundamental, structural, systemic racism issues within our country that continues to disproportionately make us suffer the most. And that's not going to change until we resolve those things.
Yeah, absolutely. And I just wanted to quickly add that, we're having this conversation around the vaccine trials in our communities, but until, you make your decision about whatever it is that you want to do, there are things that we can do to protect ourselves. I believe Dr. Bailey already touched on several of those things. So still wearing our masks, keeping 6 feet apart whenever, we can, hand washing, and please get your flu vaccine. I saw somebody ask who got the flu vaccine last season. I did. And who plans to get it? I do. And the reason being that when you have COVID overlaid on top of flu, that really portends to a really bad outcome. And that's not what we want to see. We don't want to see the numbers of Black and Brown people, doubling, tripling, dying from COVID because they have flu on top of that. So I'll just leave with that. And I know Dr. Wallace is trying to close this out.
Yes, we are at just about time. So I want to give everyone about 30 seconds for any final thoughts before we end.
Information. I'm sorry.
No,
information is justice. Knowledge is justice. Make sure and trust in the science. And come to, we're going to try to be visible and give opportunities for us to address questions. But yes, information is important. Good information.
And I'll just say for you, for yourselves, just follow the science and pay attention to follow sources that you trust. And I know that you have governors like those in New York, in New Jersey, et cetera, or even your state health department, if you trust that as a source as well. Just follow the science.
I would just say.
Oh, go ahead.
No. My only comment is vote. Your voice matters. It's important. Vote locally, vote statewide, vote nationally and federally. Your vote counts, your vote matters.
Vote early.
Yes. Make a voting plan.
You stole mine, Errol. So yes, please vote. And on top of that, just the tales that I said earlier, and then also look to your communities, the people that you trust. If there are people who are patient advocates within your communities, the doctors within your communities, the scientists within your communities, the pastors within your communities, the leaders, if you are looking to them and if they are providing, good information for these sources that they trust, then I believe that, you will have the right information you need to make the best decision for yourself.
Thank you all. Thank you all. We were not able to get to all of the questions that came through, but we will send responses out to those questions that we have. On behalf of the COVID-19 Prevention Network, I want to thank our esteemed panel for taking the time to speak with us today, sharing their voices, experiences, and themselves to bring attention to some very important issues in a time when we are looking for answers and a way forward through this uncertainty. I want to also thank all of you who attended this episode of COVID in Black, and we hope that you found this episode enlightening and informative. Please stay tuned for future episodes. Again, if we didn't get to your questions in this session, we will post them on Facebook and send them out via email. The recording of this episode will be shared as well. If you're interested in learning more about the COVID-19 Prevention Network, if you have general questions about clinical research or considering volunteering for a COVID-19 trial, please visit www.preventcovid.org. Thank you again. Have a great day, or evening, or night.
Or night.
Or midnight.
Thanks.
Thank you.